Okay. You know, I think this last time we were talking about COPD, and I was mentioning a case study. I hadn't posted anything recently. I wasn't sure if these students in transition to practice were going to view these. I see that some of you have, but we're talking about this case study of this guy who has some difficulty breathing, and I think we ended up somewhere around 18 or 20 talking about the pathophysiology on the slides. It is talking about the pathophysiology of COPD. And then we looked at some of the things like hypersecretion of mucus, cilia breaks down, the hyperinflation of lungs. You can see blood gas abnormalities, both oxygen and CO2, even changes in the pulmonary vasculature that can lead to pulmonary hypertension and right heart failure. Often you see heart failure involved as well. But anyway, he says he feels better sleeping in a recliner, so that would be orthopnea. His shoes are tight at the end of the day, which could reflect some right heart failure, edema, and he's wearing oxygen. So, you know, what are your thoughts about that assessment so far? So it's a progressive disease that develops usually over decades. We look at diagnosis in terms of cough, sputum production, dyspnea, and exposure to risk factors. If it's younger than 40 years or younger, developing, you look at the other causes, especially the enzyme, the genetic risk we talked about earlier. A lot of people come in for care because of dyspnea. They can become wheezy, they become congested, they are higher risk for infections, use intercostal and accessory muscles like the sternocleidomastoid muscle. They can be underweight oftentimes because of the expenditure of energy, and they require more calories, and they're often chronically fatigued. They have clinically, they have prolonged expiratory phase, so a longer than normal expiratory phase. It's not your normal 1 to 2 ratio. They can have wheezing as an element of reactive airway disease. They definitely have decreased breath sounds. They have an increased AP chest diameter. They often will lean over a table, and when you see them in the hospital, they elevate their diaphragm to help breathe better. They use pursed lip breathing. They can actually be polycythemic because of chronic hypoxemia, so they have more red blood cells to increase their oxygen carrying capacity. So over time, the PaO2 will go below 60, and their oxygen saturation may go below 88% on room air. And they could also develop hypercapnia. PaCO2s are greater than 45. And as I said, polycythemia develops in bone marrow, increasing bone marrow production of red blood cells for increasing oxygen carrying capacity. So we have different classifications: mild, moderate, severe, and very severe. These come off the gold classification that you can go to, but this is more for providers than anyone, but it's a gold classification. Other complications: cor pulmonale, exacerbations, typically a respiratory infection. They can develop acute respiratory failure. They can also have peptic ulcer disease. They have cor pulmonale, right heart failure. There's some clinical symptoms: descending neck veins, hepatomegaly, in the right upper quadrant, tenderness, peripheral edema, weight gain. Other diagnostic studies include EKGs, chest x-rays, a right heart catheterization, echocardiogram, BNP levels. Often their exacerbations are some kind of a bacterial or viral infection. Treatment, we use, of course, the short-acting bronchodilators, corticosteroids, antibiotics, and oxygen. We want to be careful with the use of sedatives like benzos and opioids. Our pulmonary function testings that we do show a reduction in chest wall volume or chest volumes. They have just different volumes, FEV1, FVC ratio, which I won't get into talking about the pulmonary function testing. Chest x-rays are important, history and physical exam. There's a COPD assessment test called the CAT test. There's other kinds of testing, a dyspnea scale. There's lots of other diagnostic studies. ABGs typically find a low PaO2, high PaCO2, a low pH if they're in acute failure for acidosis, and an increased bicarbonate level, and this is usually compensating for the hypercarbia, and it's usually seen late in the disease progression. So I mentioned the GOLD initiative, the American College of Chest Physician Guidelines. The biggest impact is, of course, smoking. So we want to get them to stop smoking. We know the impact of bronchodilators, anticholinergics like Spiriva, and we used to use Atrovent. Those are both long-acting anticholinergics. Inhaled corticosteroids like and combined medicines like Advair, but fluticasone is one. There's many different kinds of inhaled corticosteroids. Sometimes drug therapy like antibiotic therapy, azithromycin, fluoroquinolones, Combivent, which is ipratropium, which is a anticholinergic, and albuterol. There's the need perhaps for long-term oxygen therapy. That we want to improve exercise capacity. We want to HOMO2, and you see different delivery systems, low flow, high flow, mostly low flow for these patients. I'm around 73 right now, so there's some talk about education with oxygen use and CO2 narcosis because of high oxygen levels. We don't really know if that's verified in the research or not. With oxygen therapy, they can have improved exercise tolerance. So they're going to need respiratory and physical therapy, types of breathing exercises, retraining, percussion, vibration, postural drainage, pursed lip breathing, coughing. There's other things like the flutter valve and a capella, which helps shake the chest wall to break loose secretions. And there's a picture of that in your slides. Nutritional therapy is extremely important for these people. Smaller meals is more appropriate. High calorie, high protein diet recommended. Fluids, they need fluids. There's other interventions like bulectomy and lung transplantation, which is not very successful usually. Bulectomy helps reduce the functional, actually increases the amount of space for viable lung tissue to operate in the chest wall. Nursing diagnoses are important. So, on the slide 106, we have ineffective airway clearance, impaired gas exchange, imbalanced nutrition, less than body requirements, risk for infection, insomnia, and others. So, we want goals to prevent the disease progression, ability to perform ADLs, relief of symptoms. Smoking, of course, occupational exposures, reduce them. And I think that's it here. Pulmonary rehabilitation is important. Oh, there's other things here. Expected outcomes, normal breath sounds, effective coughing, blood gases that are normal for the patient, and feeling, like they have a quality of life. And then there's an nurse reviews arterial blood gas of the patient, which would indicate the patient has later stage COPD. Just remember, in a later stage COPD, patients usually have maybe a low or low normal pH, and a high normal or above PaCO2, and a high normal or above normal bicarbonate. Though this indicates a compensated respiratory acidosis. So what happens is chronic retention of CO2, then the kidneys begin to conserve bicarbonate to help normalize the pH. So as you look at those, you look for the one that's pretty normal pH-wise. So it would be 752 or 732 there, or it might be 732, 58. PCO2 is A, 60, and a bicarbonate of 30. So B is a little bit low, and the PaCO2 is low, and the bicarb's also low. So that would be it. It is A, but you can look through that. And that's the last slide, and I'm going to end this at 11 minutes.